is Gift Onwenna, um, and I'll be presenting the first of 4 slides on our global health presentation. This presentation is about the Cambodian community, and this presentation was prepared by Hailey Tran, Gift Onwenna, and Monica Brice. Introduction. Safe sanitation in Cambodia is a significant challenge, particularly in rural areas where many people lack access to improved sanitation and safe water. While progress has been made, open defecation remains a major issue, especially among the poorest rural populations. Improving sanitation and access to clean water is crucial for public health and economic development with the goal of universal access by 2025. Inadequate sanitation infrastructure and low public awareness continue to undermine the health of Cambodian communities, with rural provinces such as Kampong Chang facing high rates of sanitation related illness. Therefore, addressing this issue is essential not only for reducing diseases but for improving dignity, educational outcomes, and economic development. The proposed health promotion initiative that we're presenting today is called the Clean Steps Cambodia. The Clean Step Cambodia has a goal to increase knowledge and promote behavior change regarding hygiene and sanitation through peer-led education, culturally appropriate teaching tools, and practical demonstrations. This program includes village-based hygiene workshops led by trained community health educators, culturally adapted visual materials like storyboards, posters, and short videos. It also includes school sanitation clubs to engage children as hygiene ambassadors. And finally, live demonstration on proper latrine use, hand washing with soap and water storage. Now, we are not relying on imported models for our Clean Step Cambodia. Rather, we are relying upon local values such as community unity and respect for elders to foster grassroots involvement and sustainable behavioral change. As I mentioned earlier, that the program location is the Kampong Chang province. And the choice of Kampong Chang actually allows for meaningful impact and scalability to other provinces. Learning assessment. To ensure the success of the Clean Steps Cambodian Sanitation Education Program, assessing the learning needs of participants is a critical first step. Therefore, we're going to be doing this through the use of pre-program surveys with using pictorial and oral formats to accommodate low literacy levels. We're also going to be focusing on group discussions with men, women, children, and elders to explore their beliefs and taboos and local sanitation behaviors. Also, key informal interviews with village leaders, teachers, and health volunteers to understand community priorities and misconception about the Cambodian communities. For our data collection methods, we'll be using the combination of quantitative and qualitative methods like structured interviews and surveys, observation checklists, focus groups and feedback sessions, school-based pre and post tests for children involved in sanitation clubs. This data will be collected with the use of the Kobo toolbox, which supports offline data entry for remote areas. Also, there are going to be barriers and cultural adaptations that we're going to be considering in this our initiative. This includes low literacy and high literacy, gender dynamics, religious influence, and financial constraints. Sample questions for assessment and evaluation. These questions will be adapted into visual and oral formats considering participants' socioeconomic, cultural, and literacy factors. First, we're going to be asking, do you have a toilet or latrine at home? If not, where do you usually go to relieve yourself? How often do you and your children wash hands with soap and water? When do you do this? Can you show me where your family stores water? How do you keep it clean? Have you had any health problems in your village caused by dirty water or poor sanitation? What are they? What do you think makes water clean or dirty? What have you heard about hand washing or using a toilet from your village leaders or monks? Do you think building a latrine is important? Why or why not? If a program offered help or training to build toilets, would you participate? Who makes decisions in your family about building new things like latrines or water storage? Do you think children can help teach others about hygiene? And how do you think they can do that? These questions explore knowledge, beliefs, economic factors, and decision-making patterns to guide appropriate educational strategies.
Health Promotion Model. This program is guided by the Health Belief Model, HBM, which addresses key factors influencing health behaviors. These factors include perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cues to action, and self-efficacy. The HBM helps health professionals create interventions to focus on addressing patients' beliefs, encouraging preventative behaviors, and overcoming barriers to action. The health belief model can be used to promote safe sanitation practices in Cambodia, specifically in rural areas by educating communities about their risks of getting fecal diseases or infections due to unsafe sanitation. Share and educate how diarrhea that is left untreated can lead to severe malnutrition and dehydration. Educate how using proper waste disposal and hand hygiene can reduce illness and improve overall health. Recognize obstacles such as costs, lack of resources, cultural beliefs, and access to toilets and find ways to attain resources at a low cost. Health promotion, objectives, and SMART goals. Objectives. Number 1, increase community awareness. Educate on health risks associated with open defecation and poor sanitation. Number 2, encourage the construction and proper use of toilets in households and in close proximities to work and schools. Number 3, motivate consistent hand washing using both soap and water, especially after having bowel movements, urinating, before eating, and before handling food. Number 4, strengthen the community's accessibility to maintain and sustain sanitary areas. Health promotion objectives and SMART goals. SMART goals. Specific. Providing education on hand hygiene to 90% of Cambodian households and provide toilets to at least 85% of households. Assign sanitation monitors in the community to monitor the consistency of hand washing and keep their community accountable. Measurable. Use observation checklists to monitor hand washing, at least 35 assigned sanitation monitors to check in with homes to ensure proper hand washing is taking place at the right times. At least 3 in 5 of the visited homes should have a toilet in their homes. Achievable. Educational sessions will be close to home using literacy levels that are the most common in this community. Create hand washing stations and provide soap in all schools and work areas. Relevant. Prevents diseases that cause major illnesses and dehydration in rural communities. Creates permanent and sustainable health behavior changes. Time-bound. Achievable in 12 months from the start of intervention. Training assigned sanitation monitors in a span of 2 to 3 months. Patient education activity plan. Always use a toilet and avoid open defecation. Wash your hands with soap and water after using the toilet, before eating or preparing food, and whenever your hands are visibly soiled. Always keep water stored in a safe area, free of contamination. Make sure to keep toilets and hand washing areas clean. For the educational portion, get into groups of 3 to 5 people and follow the instructions of the assigned sanitation monitors for proper hand hygiene instructions. Demonstration of washing hands with both soap and water. Education and demonstration on how to use toilets and how to properly dispose of feces. This educational activity should be anywhere from 30 to 40 minutes.
So I will go over the social and cultural determinant of health. For cultural determinant, we have 3 different ones: traditional belief and practices. Some families prioritize traditional medicine or religious spiritual intervention over formal healthcare, especially when children fall ill. Belief about illness causation, such as viewing illness as spiritual punishment, can delay or prevent seeking professional care. Gender norms also play a big role. Mothers are often the sole caregiver for children, but their health-seeking behavior can be influenced or restricted by male household members. Cultural expectation can limit women's access to health information and services. Community norm and trust. Trust in healthcare workers and understanding of child health intervention can vary widely, affecting uptake of services like vaccination or nutritional support. For social determinants, poverty plays a huge role. Limited financial resources restrict access to healthcare services, transportation, nutrition, food, and safe living conditions. Family may prioritize work or food costs over healthcare expenses. Education and health literacy. Low education level among caregivers can lead to poor understanding of health needs and available services for children. Misconception about disease, prevention, and treatment are common. Access to service. Geographic barrier, such as remote villages, and inadequate transportation make it difficult for families to reach health center. There are also systemic issues like understaffed clinic and limited outreach by community health workers. Social support and network also play a role in this. Family structure and support from extended family or community leader influence health behavior. In some cases, isolation and stigma among poor family or ethnic minority reduce service utilization. Okay, so I will talk about research and evidence. A study by Slinger 2019 to explore how rural Cambodian communities view sanitation and how well they work together to improve it. Rather than relying solely on standard survey tools, the research used in-depth interviews and focus groups to better understand the local belief, behavior, and social dynamic around sanitation. They found that people's willingness to invest in sanitation was shaped not just by health knowledge, but also by trust in neighbors, shared goals, and community leadership. The study showed that to truly capture how communities think and act, especially in a culturally unique setting like rural Cambodia, it's essential to adapt tools and methods to fit the local context. This kind of groundwork help ensure the future sanitation programs are not only more accurate in measurement, but also more effective and respectful of the community they aim to serve. Another study in rural Cambodia explored how offering partial subsidy could help increase latrine sales among poor households. The result was promising when subsidy were offered specifically to poorer families. Latrine sales went up by about 14 to 16%. Interestingly, this boost didn't come at the expense of sales to wealthier households, which remained steady. This suggests that well-targeted subsidy can generally help the poor without disrupting the broader market. The study also found that the subsidy program were more cost-effective. With more households buying the electrician, the overall cost per unit dropped from $54 to $38. That mainly because the higher volume of sale helped bring down administrative and delivery costs. The success of the program hinged on accurately identify low-income household, something Cambodia was able to do using its existing ID pool system. The study also pointed out that the subsidy worked more fluidly than financing options like loan, which often more delay or high rejection rate. Overall, the findings suggest that when done thoughtfully, subsidy can be a smart, efficient way to help the poorest families access basic sanitation while keeping the market healthy and sustainable.